with that, I'm going to switch gears and talk about another target where actually targeted therapy is now appropriate. And this is for patients with BRAF mutation in lung cancer. 2 to 3% of lung adenocarcinomas seem to have this. Some of them are not V600E, but if you do have a V600E mutation, it seems like the BRAF inhibition strategy is effective. We've seen this in melanoma where for patients with BRAF mutation, the V600E, which is very common there, using the combination of dabrafenib and trametinib is a standard strategy and approach. In lung cancer in the US, the FDA recently approved the combination of dabrafenib and trametinib. I personally have treated a patient with BRAF mutation, a lady in her 60s who had diffuse lymphangitic carcinomatosis in the lung. About a year and a half ago, even before the drug was approved, we started her based on being able to access the drug through a program. And she is tolerating the drug well, and her disease is almost in a near complete remission, which represents the power of using targeted approach for a BRAF mutation positive patient. Benjamin, your colleagues in France have been leading some of these trials. Talk to us about the data with dabrafenib, trametinib, and your experiences on that.
So dabrafenib and trametinib has been approved in Europe in this setting in pretreated patients. So as you said, it's only 1% of the patients. But the activity of the drug is really in line of what you see in all what we call the de-adjunction field, meaning EGFR inhibitor, ALK inhibitor. This is really the same figure. So the response rate is in pretreated patients, meaning post-chemotherapy, 67%, and the PFS 10 months. And my colleague is presenting at ESMO the data in frontline, and the figures are exactly the same. Response rate roughly 60%, and 10 months PFS maybe a bit better, in fact. So it is completely changing. It means it gives at least 1 year of disease control, and we have treated some of these patients with BRAF inhibitor in the trial, and one of our latest patients has been treated since 5 years, and she is still in very good shape with the disease control. It's a very potent combo, and the very nice thing here is that each drug alone is quite toxic, but both combined are less toxic. I mean, the toxicity profile is not an addition of the two. It's less toxic, and you have just to deal with a few fever peak, some skin issues, fatigue sometimes. You might have to decrease the dose because all this toxicity is dose dependent. But the combo, the tolerability of the combo is very, very good. So I think it's really a standard of care, and all the patients with this kind of mutation must at one point, I mean, give chemotherapy is not a bad thing in this patient, but at one point they have to receive the combo.
So to follow up on that, if you had a BRAF mutation positive patient, would you give the combination as first-line therapy, or would you still give them platinum-based chemotherapy?
Well, if it's available, I would definitely offer the combo up front. I mean, there is no discussion that in the other area, EGFR, ALK, TKI is the preferred choice up front. It's exactly the same figure here.
So that brings us to then the issue of testing. We are used to testing for EGFR and ALK. Now ROS1 obviously part of the mix, given that crizotinib is an approved option. Is BRAF testing part of the standard testing platform at your institution? Share your thoughts on what are...
I work in a cancer center, so we have an NGS panel for all patients, but I think that this can't be for the clinical routine practice for all the centers, because at least in Italy the combination is not yet available. So I think that it must be considered as a routine test when the drug will be available for everybody.
Giorgio,
it's already part of a seven panel genes. We are doing a 7-gene panel, in the routine clinical practice for non-squamous non-small cell lung cancer. And we are moving to a 50 genes panel in a few weeks that we would like to offer systematically to all patients with non-small cell lung cancer. And I agree again with Benjamin about the fact that we need to offer this treatment possibility. It is true that it's only 1%, probably less than 1%, but it's important to understand. Well, it's the same story with the skipping of the exon 14. No one was thinking that crizotinib was working in the exon 14 skipping of the gene, of the MET gene. But we have another opportunity. With these most likely 1%, probably we are moving in the right direction. The issue is that we are used to talk in these educational activities. We are used to talk about thoracic oncology. We are not trying to be cross-contaminated with the experience from other type of tumors. But at this meeting, for instance, attending to a session on melanoma, I saw that our melanoma friends, they are moving in the direction. I know that lung is not melanoma, I agree with you. But they are moving from targeted therapies, they are using combo, as we are used in this case. And they are considering also immunotherapy, or they are considering in a later stage, because obviously the combination of trametinib, of cometinib, and the RAF inhibitor in combination with immunotherapy is pretty toxic. But again, they are running studies in which the two approaches, immunotherapy, there is no way that is effective in melanoma. They are assessed in a sort of sequential treatment. Well, it is true that we said before that the EGFR is not the right setting for immunotherapy. It's probably is not true for ALK. Well, in this case, I'm still considering that probably we need to look to the sequential approach. It is not easy to do studies because David Blanchard did a study a limited amount of patients because it means to screen a lot of patients for BRAF mutation. But having this kind of experience with the BRAF inhibitors in combination with the MEK inhibitor, probably the next stage, at least for me, it could be to consider a study of immunotherapy in this field.
And regarding screening, the tricky thing here is that in EGFR mutant or ALK rearrange, it's easy, it's light or never smoker. So you screen EGFR, then ALK, and then ROS1.
That isn't the case.
It's not the case for BRAF. So there is no patient's phenotype. Half are heavy smoker, half are never smoker. The only thing, it's mutually exclusive with other mutation like EGFR, KRAS. So if it's not in the initial panel, I think it's really something could be look at in the, for example, KRAS, EGFR wild-type patients.
So clearly, we now have at least 4 driver mutations that we should look for patients with non-squamous, EGFR, ALK, ROS1, and BRAF. And of course, an NGS panel will get you all of this information, but whatever panel your institution is using, make sure that you have these 4 genes covered for non-small cell lung cancer patients, because it has a direct implication with, in the US, FDA-approved therapies for each of those.